Just unmute yourself. I'll just unmute you. So congratulations on passing MRCPCH.
Thank you, Dr. Mohammadi.
Okay.
How
So
are you?
do you need 5 minutes, you said? I'll just pause the recording then.
Yeah.
Yeah. So we'll start with your stations first, and you can start now. Okay.
Yes. My first station was development, and the scenario was that a 3-year-old child and take the detailed history and do the assessment of social and speech, heading and speech. So in first I took the history, and it was that the child was born normally and it was nothing significant. And during the birth or natal and postnatal antenatal, just it was a stain over the face and the head, and that was the clue at that time for the Sturge-Weber syndrome. And after that he had fits, and he never had hospitalization since birth to the age of the 3 years. During this year, he has multiple episodes of the fits. For that, he was on anti-epileptic drugs, and the name of that drug was not remembered by the mother. And she was on regular medicine follow up, and but along with that, the child was delayed. And I inquired all about other domains, and he was delayed in all domains of the development. And the examiner specifically asked me about the development age of the fine motor as well as gross motor, and it was like 1.5 year in both gross motor as well as in the fine motor. In the assessment part, the examiner was asked during my assessment when I was assessing social and hearing speech. The one thing is that was bothering me. I don't know it was the right or wrong, but examiner were asking, interrupting me in between what you are doing. And when I was selecting the choice, he was asking which choice you will use for which purpose. And or even during my assessment he was asking, what are you assessing, what does it indicate, what are you assessing. But overall it was good, and I got full marks even their interruptions. That was the development. And
That's
it was Sturge-Weber with the social and hearing speech, and the child was global developmentally delayed.
okay. Any questions, guys? So it seems the child had some intrauterine insult, right? There's no postnatal insult.
No, there was no any insult. Just there was a stain over the face that was prompting toward the Sturge-Weber syndrome, and along with the fits, and that fits was like infantile spasm according to the presentation when I asked. So on that basis, I put the diagnosis of Sturge-Weber, and he was happy that I picked the case.
Okay, so the mother told you about the rash on the face?
Yes, I asked any dysmorphic feature, any mark, any stain. Now, after inquiry, she told me.
Yeah, because they usually don't say. So this is the second feedback I'm hearing, that they're saying about the port wine stain. Yeah, okay, that's good. So I need to ask the mother about the facial features and yeah, any skin rashes and all that. Okay,
Yes.
so any questions, guys? This is very important in development. You have to rule out syndromes and everything, and they're giving neurocutaneous syndromes as well. Okay, let's go to the next one.
Next was my next station was my history, and it was a child 2.5 year old, and it was basically epilepsy present with the fits, and it was uncontrolled fits. Even though on medication, he was on sodium valproate, and I ask each and everything in the history related to the fates treatment and the similarity with the first episode and the second episode, and I ask each and everything, and most of the questions was not known by the mom as well, in the development as well as in the history. I inquired a lot of things, and the mother was saying that I don't know, I have forgotten, I don't know, I have forgotten. But important thing is that you have to inquire each and everything, and you must reach up to the diagnosis. That is the main thing. And
Yeah, have to
yeah,
in and find out. But
yeah,
sometimes the role player is not even the mother. That's another issue that happens, especially in development. So, I mean, you can at least say that I'd like to find out. Development
yeah,
history, basically in 9 minutes, is a very short time. So you have to
yeah,
be very quick in the development.
yeah. Yeah, and you should be very specific to ask the question in history, either in the development or the history or general history, because it's very. I think you have to find the cause and rule out the other differentials. What you are thinking, you have to compose yourself during the history taking, either from the general history or from the development, because I think you must rule out each and everything. And the role player, most of the role player I have seen that they are schemed like that. We don't know. We have forgotten. I don't know, like this. So you have to inquire each and everything from the history.
Yeah, you should do your best to find out as much as information you can. It's another thing if the role player, is not telling you, that's a different thing altogether. But remember, I mean, in development, especially the history, you have to be very fast here also. It's only 13 minutes. You have to ask everything. And I mean, from birth, if the child has epilepsy, you have to ask about development here as well. So, because the child is small, it's only 2.5 years old. So, development history should be asked, birth history, everything is significant. Why does he have epilepsy and all that? Okay.
Hmm.
What was significant? Anything significant in the history?
I think there was nothing. Just they emphasize me on the differential diagnosis, and I put all the differential diagnosis like epilepsy or new onset seizure or and metabolic syndromes as well. And because it was, I think my examiner was happy when I want to rule out the metabolic cause of the epilepsy, and when I told all the investigation about the metabolic disorders, she was so much happy at that time. So we just
Yeah.
don't keep our diagnosis just on the epilepsy or seizure disorder like this. We have to rule out other metabolic causes of the fits and seizures.
Yeah, you have to rule out neurocutaneous syndrome as well because the child had uncontrolled seizure, right? So usually uncontrolled seizure, there might be an epilepsy syndrome itself, and it could be associated with the neurocutaneous syndrome or other syndromes. So development of the child was normal, or he was having
Yeah,
developmentally.
developmentally, this child was normal, and there is nothing significant in the birth history. No, not any history of the anoxia or hypoxic ischemic encephalopathy or antenatal any CNS insult. Nothing was there.
Okay, and family history also.
Yeah, family history also not significant.
Okay, yeah, but we need to rule it out, yeah. So that's
Yes,
good. So you also got full marks in this, right?
yeah.
That's good.
After that, uh,
Epilepsy is a very important topic. Everybody should know that. It's given in the pediatric guidelines. Read it from there and other sources as well. All right. What was next?
Next was the communication, and it was a 15-year girl who has concern about her growth, and all his previous investigation were normal. Her mother and father both are short statured, and she achieved puberty at the age of the 12 year, and each and every lab done previously was normal. And his brother, who was 2 years younger than her, he is tall, and just we have to communicate why she's short, and she was emphasizing that I want to be a model and how I can be a model with the short stature. I want to take the growth hormones, and she was insisting on that this, and especially she was insisting that why my younger brother is so much elder and too much heighted, why not I am, and we are the kids of the same parents, why she was like this. So
You have to, I
I,
mean, yeah, this is actually true that in the obviously we won't go too much into details, but you have to say
hmm,
that not only the parents influence will be there, but your environment also will be affecting you, right? Maybe he is more active than you, and the body releases growth hormone. You can also try, exercising, and
yeah.
natural growth hormone is better than we give you anything, which will cause side effects, right? So that's how you should do it. So what did you say to him? I mean her.
Yeah, I just said that I told about the mid-parental heights, and I told like that. Yeah, if he is your younger brother, it doesn't matter. There are some kids are acquired the good height, some acquire like mother and father, because some fall on the higher score and some fall on the lower side, so it may be like this. I plot, and I yeah, I put on that, and I try to understand her, and she got it.
Okay, that's good. You explained more scientifically on
Yeah,
the mid-parent height, and the maximum potential your brother reached, and you're on the minimum one.
yeah. Because at that time I was thinking like this, and whatever coming in mind, I just told her, and she got agree on this. After that, she was insisting that there is a therapy, some medications are there, and I know some other girls who are taking this medication, and I want to take that medication. So I explained that no, this is not significant in your case, and it will not be responsive in your case. It have some side effect, and you have a familiar short stature. That's why. And in the last, when I was asking for the consent, she was again insisting that I want to take the growth hormone, and in the end I don't have time to sign out. Just so I said that we have you have, I know you have a lot of question, we will arrange another meeting for you to explain your concerns further. She said no, I want to know all these things in this meeting, and the time goes, and
So basically,
yeah.
interesting. And she was not satisfied with your side effects and everything, huh?
Yeah, but the examiner were very much satisfied, and I got full marks in this.
Okay, okay, that's good. Because sometimes a role player can be, indicating that you need to say something which is not being said. That's why they keep on insisting till you see the right answer. But yeah, she was just an aggressive role player. This was not the
Yeah.
case. Good.
Hmm. And after that, I have another scenario of the communication. It was the newborn baby, newborn 4 weeks old baby with the pyloric stenosis. He was having some electrolyte imbalance, and it was correcting by the IV fluid and planned for the surgery, but there was no bed vacant in the surgical ward. So surgeon delayed the surgery, and asked the pediatric team to keep the patient in the pediatric ward until they have the free bed, and after that they will do the surgery. For that, we have to counsel the mother for the management and for the delay of the surgery.
Yeah, this is
That
coming along sometimes they're giving child has fits, and because of the delay of surgery, he has developed fits. In your case, it was there was no complication. But actually, I mean, I think you explained that the child needed to be stabilized first before we go for surgery. I think that's what you told her, right?
Yeah. So I asked for the concern, and I said that there is some electrolyte imbalance, and we are correcting by giving the fluid through the tubes. And she was asking that why my baby is not given the feed. So I explained that it's not necessary to give the feed by mouth because it will further deteriorate him, and it will cause further electrolyte imbalance or disturbance. And we are giving the fluid through the tubes that will cover it.
Yeah, so I mean, it will not matter if you just delay the feeding
Yeah.
till after the operation. Yeah. Okay, then that's good. What's the next?
The next was the video station, and it was a newborn baby with the petechial hemorrhages over the face, over back, over abdomen, like a generalized petechial hemorrhage. And they asked me for the diagnosis, so I made the neonatal or alloimmune thrombocytopenia. And after that, he asked for the investigation and management, and questions what you will ask in the history, and how will you investigate. These were the question in this station.
Yeah, so it's a repeated scenario. You have to know the differential diagnosis of NETAP, meaning alloimmune or is it autoimmune, right? Then you will ask, of course, the history of the mother and any medication she's on. And they do always ask in the management what type of platelets. This is always asked. So the standard question.
Yeah.
So you have to give the human platelet antigen negative, just like the mother. Otherwise, it will be destroyed. And there will be
Yeah,
indication.
and
It's not like you'll give it to every child. So you should know. It's given in the guideline books as well. Neonatal guidelines. Okay, read it.
yeah, and he also asked for the other treatment option, and I told about the IVIG. Basically, he want to hear IVIG and platelet transfusion, and which type of the platelet we will give in this condition.
Yeah, they always ask about which type of platelets because they want to hear, is it the
Yeah.
mother platelets or the, babies? Obviously, just like, the antibodies, will destroy the mother's baby's platelets, so we will not give a positive antigen, positive platelets. So, yeah.
Yeah.
Next, what it was?
Next was the periorbital cellulitis, and it was also for wholly solely from the guidelines. And he asked me the differential diagnosis. After that, history questions, and examination finding, management, and complication. Even though it was the periorbital cellulitis, but he asked me each and every complication of the orbital cellulitis, involvement of complication, like even he went for the cerebral abscess, its management, and when we will involve the pediatric surgeon, like this.
Yeah, because normally the orbital cellulitis comes, but this time they've given periorbital. But of course, we have to, rule out orbital cellulitis, and it will be similar, the same history and everything. Okay.
But in this video station, some other candidate who were appear, they just were only for the discussion of the periorbital cellulitis, not more than this. But from me, they ask each and everything of the orbital cellulitis as well.
Okay, I mean, and the same examiner, or it was some
Yeah,
other?
same examiner, and just they ask about war history, investigations, management. All were from the periorbital cellulitis, and few complication from the of the periorbital cellulitis. But from me, he asked each and everything of periorbital cellulitis as well as orbital cellulitis.
Okay, that means you had a good timing. I mean, he had to enough time to ask you
Yeah,
both of it. Yeah.
yeah,
All right, that's good. I mean, we've done this quite thoroughly, I think. And I told you
yeah,
this is a very important topic. It comes also in the history as well. Okay,
yeah.
next.
After that, I had my clinicals. Yeah, I had my clinical, and first is clinical was my 3.5 year old child, and my command was do the abdominal examination. And during my abdominal examination, I found the case was a glycogen storage disease. It was a hepatomegaly, and the child was wasted in limbs while abdomen was distended, and there was no splenomegaly. He was not ectatic, not anemic so much. So I kept my first differential as a glycogen storage disease. Other were infectious disease like viral hepatitis or due to the parasitic infection, and other sickle cell thalassemia and malignancy. All were my differential diagnosis, and they ask the questions regarding glycogen storage disease. What is how will you investigate and how will you manage the child?
Okay, yeah, the glycogen storage disease is a very common case that comes not only in Pakistan but also abroad, other countries as well. So you have to know, other than hemolytic anemias, you can get the isolated hepatomegaly, and this is one of those cases. And yeah, so you should know the cases that come commonly, so you know how to do it. You have no time to, at that time think in the exam. Very quickly you have to answer. All right. So what did he ask in the management? Anything specific?
Nothing specific, just I told that we will first I told about the investigation, that we will go for the full blood like fasting blood sugar, serum uric acid level, lipid profile, and after an ultrasound abdomen. After that he asked me how will you manage, so just I mentioned the we will correct the hypoglycemia, intermittent fasting, like overnight feeding and starch. All these things I just mentioned.
Okay. So I mean, basically, he discussed the glycogen storage disease type 1 mainly. Okay.
Yeah.
Okay. All right.
And
Next.
next was the respiratory station, and it was pleural effusion, and command was do the exactly I don't remember what was the command for respiratory, and I started the examination, and it was a pleural effusion, and test tube was just removed on the day of exam or just one day before, because there was a dressing, and all findings were suggestive of the pleural effusion. There was the mark of the empty placement. So I put the pleural effusion due to some infectious disease like pneumonia, like parapneumonic effusion and tuberculosis, and other I kept like malignancy or connective tissue disorder like this. And after that he asked me the investigation and management. It was so long during my discussion that just he asked me the management and the bell rang at that time. So we don't reach up to the management. He asked me the question, but we don't have time to respond him.
Okay, but you have 4 minutes in between stations. You can answer a little bit and then leave. Don't
Yeah,
run away as soon as the bell rings. Okay.
yeah.
Uh, So basically, he had a chest tube which had been removed. So I mean, there was a. Did they give you any hint? There was a chest tube there. I mean, could you see suturing done or what?
Just dressing was there. Dressing was
Dressing.
there. Yeah.
Hmm. And they didn't give
And
you any drain on the side in the surroundings or anything.
no, like this. Nothing like
Nothing
this.
in the surroundings in any of the clinicals, right? No medication, nothing.
Hmm. Even though I was searching for that because we have to see the surrounding. I searched for that, but nothing
Yeah,
was there.
they're not.
Actually, thing was that the cases were kept on changing, and before me, there was the CVS case that was stopped for VSD like this.
Okay.
So there was nothing in surrounding for my patient because the patient was changed at that time during my station.
Yeah, I heard that there was a frequent changing.
Yeah.
Okay, so what was next?
The next was my MSK examination, and command was the child was 8 year old, a wheelchair bounded patient, and the command was to do the PGALs. And it was very much difficult because it was the wheelchair bounded and he can't walk. And I asked mom that can he walk. So she said yes, he can walk with support. Then I asked from the examiner as well as mother, can he walk, and please can you do this. Mother said yes, okay. And with support, child tried to walk. And I found at that time that he has a calf muscle hypertrophy and the tiptoe walking. After that I asked to sit on the floor to check the Gover sign. And the child perform and that sign were positive. And after that put the child on couch and do my the whole PGAL examination as much as I can do, because there was no restriction of joint. It was totally the case of the DMD, but the command was PGALs. And when I performed all the PGAL maneuver, whatever I can do, I offer her to the examiner that I want to do the CNS examination. She said yes, her CNS examination is normal. After that
Okay.
yeah, I have some time even after that. And after completing my examination, I told each and everything. Basically I found a general finding of the DMD, like scoliosis. No, there was no scoliosis, but there was lordosis.
Hmm.
Lordosis and calf muscle hypertrophy and tiptoe walking contractions was there, and Gover sign was there. And I got full marks in this station, and it was so much difficult. I would like to say it was so much tricky to examine that child.
Yeah, I think you have to remember that not all children will be walking.
Yeah.
Many people have, told me then when they find a child in a wheelchair, especially if it's like an older child, it's very difficult for them to do a neurological examination or even this MSK if he's
Hmm.
not, able to walk and I mean to do the reflexes, everything, tone, power on the. You have to learn how to, do it not only on the bed, but also
Hmm.
if a child is wheelchair bound. Sometimes the examiner says just do it on the wheelchair. So you have
Yeah.
to learn to do manage that as well.
Yeah.
Anyhow, but they told you to do a PGALs of the upper limb as well with the lower limb.
Yeah. I do PGALs of the lower limb as well as of upper limb and the neck as well.
Okay, so full PGALs. All right.
Yeah, I do the full PGAL.
Okay, that's good. I think this is a very, I mean, we practiced this case quite well. It was not a hard case. And you found the calf hypertrophy, so that's very important. And the lumbar
Just
lord.
it was very much tricky how to handle at that time that patient and how to examine. I think that was the main point.
Yeah, you should not lose your cool just by, seeing a child in a wheelchair. Oh my God, what is this? Like that.
Hmm.
Just, go with the flow, properly examine and,
Hmm.
inspect the patient. The minute you see calf hypertrophy, it's all easy after that.
Yeah.
Okay, so what was next?
Next was my senior station, and child was 11-year-old, and my command was do the motor examination of this child. And I start from the gate, and the gate was normal. And after that, I'll do the motor examination of the lower limb and upper limb. Upper limb motor examination was completely fine. Lower limb examination reflexes was normal, but the plantar was not responding. It was absent. So, and there was somewhat distal muscle atrophy. Otherwise, there was no any other significant finding, and this was the case of the transverse myelitis. And the examiner asked me for the diagnosis, differential diagnosis, investigation, and management.
Okay, so the child was able to walk in transverse myelitis. He's
I
recovering.
think it was a recovered phase because there was nothing in the gate. I
Okay.
don't find any significant gate finding.
Yeah, but the planters were equivocal, you were saying. They're
Yeah,
not going
yeah.
down. Okay.
No, it was not down going or up going. It was just equivocal. Yeah,
And the bulk and power?
yeah. It was always power was also normal. It was because he was walking normally. He was doing each and everything normally in lower limb as well. Upper limb was completely fine. And lower limb I found just not responding Babinski, negative Babinski. Otherwise, everything was normal.
Okay. And the bulk also is normal, right?
Yeah, it was also normal.
Okay. So how did you get to the transverse myelitis? What was the hint?
Basically, I didn't reach up to the diagnosis. It was so much difficult for me. Yeah,
Yeah, obviously, if you're not finding anything, it's going to be difficult to say transverse myelitis, right?
yeah,
Just based on these findings.
yeah.
He didn't give any hint, just said,
No, no, no,
mm,
and none of the examiner was given any hint to any candidate. Just they gave the command and they were just observing what we are doing.
okay, so what did you give in the differentials then? Obviously, you didn't give transverse myelitis. That's probably written in your feedback.
I give so much vague type of the differential.
Uh,
Yeah.
yeah, because I mean, if he's got normal power, normal everything, what are we
Usually
going
the
to do?
differential of the transverse myelitis is Guillain-Barré syndrome and the traumatic neuritis and polymyelitis like this. But I give a very different type of that
Uh,
differential.
in the
Hmm.
differential, did he say this is transverse myelitis or did you give it as a differential?
I kept just in my differential.
Oh, okay. So he accepted it.
It was not my primary diagnosis at that time.
Okay, okay.
Yeah.
Anyhow, so then how much did you get in this station?
I just had just passing marks in this station.
Uh, yeah, because
Hmm.
it's a weird case. We
Yeah,
yeah. Okay.
yeah.
So what was next?
Yeah, it was all to communication, to videos, one development, one history, and four clinical was that.
We've done all four. Yeah, this was a quick feedback. So
Yeah.
any questions you guys want to ask? And thanks a lot for the feedback, Sam. And good luck for the future. I'll just stop the recording so people can ask questions.
Yeah, my circumstances, it was so much difficult for me to go, and you support me throughout my journey from day one to last day. Even after the exam, you were so much supportive.
Yeah, I mean, I think that's my habit. I'm like that, but you know, recently I felt that people take it for granted, but you really appreciated my efforts and everything, and I know you had enough time. You're my
Yeah,
Facebook and everything, so I knew how hard it was for you to prepare for this exam. So
yeah,
but I'm really happy you passed. It was
yeah.
a,
You
you know,
were so much. Hmm.
yeah.
Yeah, you. I would like to say that you were with me from day one to till now. You are with me.
Yeah,
Yeah.
inshallah. So then, all right. Any questions anyone wants to ask?
Yes, I have a question.